No, ma'am.
Yeah, right. Okay, I welcome you all for our Clinical Research Committee of Oxy and Foxy webinar, first Journal Club of year, May 2024.
Not audible. Deepa ma'am, we can't hear you.
And I think we lost her.
She's joined again, madam, from the phone. Now she's joining back.
Sorry, Priya.
Yes, ma'am.
Okay, so we'll start first Journal Club of the year, May 2024. The first, I will introduce our Oxy office bearers, our Vijaya Madam. Vijaya Madam is the current president of Oxy Society, and she is the former director of Institute of Obstetric Gynecology, Madras Medical College. And Madam has a credit into her. She is a state level master trainer in EMOC and emergency obstetrics and neonatal care, as well as cervical cancer and colposcopy. She is an educator as well as a Foxy master trainer in HPV vaccination awareness. She is a UG, PG, MS and DNB examiner. She is currently working as a HOD in ESI Medical College and Hospital, Chennai. Next is our Geeta Lakshmi Madam. She joined soon. She is UGPG from Madras Medical College, and she is a teacher of almost past 22 years. She is a secretary Oxy as well as a member of Chennai Menopause Society and ISOPAP. Madam has presented many papers in various national and international conferences. And she had an original research paper in gestational glucose tolerance, and that was presented in the World Journal of Advanced Healthcare Research in January 2021. Madam's areas of interest is high-risk pregnancy and adolescence health programs and medical education. And I welcome Vijaya Madam to tell a few words about this journal club, Madam. Madam, you are muted, ma'am.
Any prayer song?
Illa, ma'am.
Okay.
Ma'am.
With God's blessings and with my profound blessings to Deepa and Priya, they are our youngest generation, I can say, who are very, very active in Oxy. And this research, you all know, it's very tough. As we think of research only, we used to run away. Somebody do and give the statistics and we'll be very happy to publish. But the thing is, it is very, very easy. And if you understand very well, the research is as simple as that, and we have volumes and volumes of clinical cases and which we fail to present. And this is a need of the hour because now the world is turning into evidence-based medicine, and recent advances are coming in a long way in OG. So I sincerely wish this meeting, this webinar should go on and attract all the youngsters to get involved in the research, and we should get more papers. And I'm also very happy to welcome Dr. Bipin sir. And we are eagerly waiting for his musical bonanza in our president's conference. And also Uma and Kurian sir for being the expert chairpersons today. And both the topics you have selected are extremely good and very practical. And best wishes, Deepa and Priya. With God's blessings, just go on.
Thank you, ma'am. We next is Priya Kanappan. Priya Kanappan is a very active young member, and she is a consultant and obstetric gynecologist from Mehta Hospitals. She is an executive committee member of Oxy Chennai for the last 4 years. She was one of the best outgoing student in Manipal hospitals, and she did a fellowship in ultrasonogram, ICOG fellowships, and she recently got a FICOG, and she's presented in papers and posters in many national conferences. With this, I will introduce our Foxy office bearers of the clinical research committees, though they will be joining late. One is Dr. Sureka. She is chairpersons of Global Women Task and currently a chairperson for Foxy Clinical Research Committee, as well as she is a coordinator of West Zone from the Practical Obstetric Committee Foxy. She has done a many project, co-faculty in many projects like DIRA project Foxy, and she is a founding member of Vice Chair, and she had many projects of 16 projects, more than 108 publications, and 8 chapters in books and 3 books publication under her name. She is a reviewer of international journals. Next is a Dr. Charmila Ayavu. She is now a VP Foxy of 2024. She is a chairperson of Clinical Research Committee Foxy, and she is an ICOG Governing Council member 2021 to 2023. Madam is also a national coordinator for many projects and a series convener of ICOG Journal Club. Today also she had a journal club at 4 p.m. Next is like our expert. It's my extreme privilege to welcome Bipin Sir. Bipin Sir is an odd person to do this. Bipin Sir is the Secretary General of AMOX 2024. He is a past Executive Council member of Maharashtra Medical Council, Vice President Foxy 2021 to 2022, and past President AMOX, and past Joint Secretary Foxy 2015, and he is a treasurer in ACOG 2013. He received a Lifetime Achievement Award from AMC 2019, and past President and Trustee Association of Medical Consultants, Mumbai. Sir is enough. Okay, sir.
I think
and today's theme is like, today's theme is like labor and intrapartum, for which I introduce our 2 moderators, Dr. Umaram. Madam is the current ACC RCOG chairperson 2024 to 2027 and past chairperson South Zone ACC RCOG. She is the examiner Part 3 MRCOG. She is a treasurer 18 RCOG and she is a consultant and director consultant Sitapati. Next is Korean Joseph sir. I was behind him for his CV for a long time. Now he has done a 2-page CVs. I'm just introducing him. Madam sir is the Director Joseph Hospitals. He is a well-known faculty. He was honored with a fellowship in Royal College of Obstetrics and Gynecology last year. With this, we'll move on to the first topic, session 1. The topic is like is from the Journal of American Journal of Obstetric Gynecology, March 2024. Single balloon catheter with concomitant vaginal misoprostol, most effective strategy for labor induction. A meta-analysis review with network meta-analysis. And the presenter is Harin Sri. Harin Sri is a registrar in Sitapati Medical College, Sitapati Clinic and Hospital. She is a gold medalist in UG and college topper in PG. Her area of interest is high-risk pregnancy and maternal medicine. And Harin Sri, over to you. Harin Sri, can you share? You can share your screen. Harini?
Harini, ma'am. Yeah. Sorry, ma'am. It was showing that I was not allowed to unmute myself.
Okay.
Good evening, everybody. I'll be presenting on the paper on single balloon catheter with concomitant vaginal misoprostol as the single most effective strategy for labor induction, a meta-review with network meta-analysis. So this study, actually, it included 11 systematic reviews, which had 207 randomized control trials with over 40,854 participants. The ARRIVE trial concluded that induction at 39 weeks lowered the cesarean section rates. So this could be seen in the fact that the rate of induction increased from 9.6% in 1990 to 27.1% in 2018. This study used the network meta-analysis methodology, and the aim was to provide evidence regarding which is the most effective agent for induction of labor. A brief introduction about what network meta-analysis actually means. It's a technique that is comparing 3 or more interventions simultaneously using a single analysis by combining direct and indirect evidence across a network of studies. It yields more precise estimates. For example, this was a study wherein there was an estimate about how a doctor would be able to give a dietary advice, though this was not a single study. The first study included where a dietitian was able to give a dietary advice, and then a dietitian was compared with the nurse. The nurse was compared with a pharmacist in a third study, and so there was an indirect estimate between the doctor and a pharmacist, which was later derived using this network meta-analysis. Methods. So the electronic literature search was the first one, and it included experienced research librarian who combed through PubMed, Embase, and Cochrane databases and focused on narrative or systemic reviews and meta-analysis. It was then downloaded into EndNote software and Covidence. Covidence is a screening data and extraction tool. Study selection. The inclusion criteria included systemic reviews and meta-analysis of randomized control trials, quasi-randomized trials, which compared labor induction agents. The data on at least one of these outcomes needed to be included in these trials, which was cesarean delivery, vaginal delivery less than 24 hours, hyperstimulation, admission to NICU, ABGA score less than 7 at 5 minutes, operative vaginal delivery. It needed to be published as a full text article or abstract, and only third trimester labor induction was included in this study. Exclusion criteria included systemic reviews that did not pool data or perform quantitative data synthesis, narrative reviews that did not undergo extensive systemic search of literature, conference papers, letters to the editor, expert opinion papers were all excluded. Those that compared different doses of same agent using same route of administrations was not included. Methods not widely employed in clinical practice focused on indications for labor induction, combination of pharmacological agents, or those who had a previous cesarean delivery. Study selection, 2 reviewers independently screened the titles and abstracts. If discrepancies arose, one third reviewer served as an adjudicator. Data extraction and quality assessment. The data extracted included the primary author, year of publication, number and publication dates of primary studies, inclusion, exclusion criteria, performance of heterogeneity analysis, sample size, types of labor induction agents employed, outcomes assessed, meta-analysis result. If there were any overlapping studies, the most recent one was included in this. Quality assessment was done with AMSTAR 2. AMSTAR 2 is assessing the methodological quality of systemic reviews, and this was the version 2 was used. It is a 16-item tool that is used for measurement of quality and methodology of systemic reviews. Assign risk of bias as high, low, or unclear. Methods for evidence synthesis. Narrative overview of clinical and methodological characteristics was done, which generated descriptive statistics, employed pairwise random effects meta-analysis. Heterogeneity was assessed using I-square and Q-chi-square test. Best agents analyzed by SUCRA. SUCRA is surface under cumulative ranking curve. Higher value indicates better performance for the respective interventions. Software considerations for pairwise direct comparison meta-analysis, package metan for Stata SC software, and for network meta-analysis, several network meta-user written commands were used. The results. So 435 studies were initially assessed. There were 318 were removed before screening. 135 remained. Out of this, 88 articles were excluded after screening the titles and abstract. 47 were then selected for retrieval, and 36 were thoroughly assessed for eligibility. And after applying the exclusion criteria, 25 were excluded, and so 11 met all criteria and were included in this study. The first outcome that we will be seeing is cesarean section. So the cesarean section rate was seen to be 21.7% across 207 RCT, which had 40,854 participants. So all the outcomes were assessed based on comparing all the agents or methods, only pharmacological agents, or mechanical methods on one hand, which were then compared to pharmacological or combination method. And each result, the best method was told when compared to what other methods, and probability of being in the top 3. For example, for cesarean section, when all agents and methods were included, it was found that single balloon catheter and misoprostol combination was the best in comparison to placebo, oxytocin alone, or single balloon catheter alone. And this method found to be decreasing cesarean section rate with a probability of being in the top 3 of 73.9%. When pharmacological agents alone were seen, it was seen that low-dose vaginal misoprostol and oral mifepristone in comparison to low-dose oral misoprostol, oxytocin or placebo were found to be more effective with a probability of 64.1% and 68.1% of being in the top 3. When mechanical methods on one arm versus pharmacological or combination was seen, it was seen that low-dose miso separately and low-dose miso with the single balloon catheter both had similar efficacy when compared to oxytocin or single balloon catheter with a probability of being in top 3 of reducing cesarean section of 76.9%. So the conclusion was that 25 mcg of vaginal misoprostol with a 30 ml single balloon catheter, there was an 87.7% reduction in cesarean section rate. This was in comparison to intracervical PGE2 gel, placebo, oxytocin, only single balloon catheter, high dose vaginal misoprostol or slow release vaginal PGE2 pessary. The next outcome that was seen was vaginal delivery within 24 hours. This included 100 randomized control trials and 16,211 participants. So here also single balloon catheter with misoprostol was found to be best, and it had an 88.7% probability of being in the top 3 agents causing vaginal delivery within 24 hours in comparison to placebo, oral mifepristone or low-dose oral misoprostol. When only pharmacological agents were seen, it was seen that high-dose vaginal misoprostol was the most effective with a 93.3% probability of being in top 3. And the last column, it was seen that single balloon catheter with misoprostol in comparison to slow-release PGE2 vaginal pessary or single balloon catheter alone or low-dose oromisoprostol alone, it had a probability of being in the top 3 with 97.5%. The next outcome was operative vaginal delivery, and this included 141 randomized control trial with 24,584 participants. The overall operative vaginal delivery was found to be at 11.4%. Here also single balloon catheter was found to be the most effective in comparison to oxytocin, intracervical PGE2 gel, high-dose vaginal misoprostol with a probability of 64.2%. Buccal misoprostol and sublingual misoprostol when compared to oxytocin had a probability of being in the top 3 of 88.9% and 79.8%. Single balloon catheter and single balloon catheter with oxytocin, but these were significant only when compared with low-dose vaginal misoprostol, and the probability of being in the top 3 was 67.4% and 65.8%. The next outcome is hyperstimulation, 136 RCTs with 26,173 participants. Double balloon catheter or single balloon catheter with Synto, in comparison to high-dose vaginal misoprostol, it had a 57% better rate in actually reducing hyperstimulation, and the probability of being in top 3 agents causing a reduced hyperstimulation was 91.1% for double balloon catheter and 83% for a single balloon catheter with oxytocin. When only pharmacological agents were seen, low-dose oral misoprostol in comparison to high-dose vaginal misoprostol was found to be most effective. 96.1% was the probability. And the last column, oxytocin with a single balloon catheter and a double balloon catheter were found to be more effective when compared to slow-release vaginal PGE2 pessary with probabilities of 84.1% and 74.8%. The next outcome was Apgar score less than 7 at 5 minutes. It included 110 RCTs with 25,249 participants. Buccal or sublingual misoprostol was found to be most effective. This was in comparison to oral mifepristone, the results were more significant with a probability of 76.6%. And in comparison to high-dose vaginal misoprostol had a probability of being in top 3 of 78.7%. The next outcome was NICU admissions, and this included 138 randomized control trials with 31,881 participants. And single balloon catheter with misoprostol was again found to be the most effective in comparison to mifepristone, had an 89.4% probability of being in top 3 agents causing reduced NICU admissions. When seeing pharmacological agents alone, buccal or sublingual misoprostol was found to be effective with a probability of top 3, 58.7%. Double balloon catheter when compared to oxytocin, the probability of being in top 3 was 59.8%. So the results summary, actually, the conclusion was that single balloon catheter inflated to 30 ml with 25 mcg vaginal misoprostol was actually the best method for induction, had a reducing odds of cesarean delivery, vaginal delivery more than 24 hours. It reduced the odds of NICU admission, hyperstimulation, operative vaginal delivery, and abnormal Apgar score. When we take each independent outcome alone, other than single balloon catheter, we can here see what other agent was best. I'm sorry. Reducing cesarean delivery, the second best option was low-dose vaginal misoprostol, oral mifepristone. Vaginal delivery less than 24 hours, the second best agent was high-dose vaginal misoprostol. Reduction in odds of Apgar scores of less than 7 at 5 minutes. Reduction in NICU admissions and reduction in operative vaginal deliveries. Second best was buccal or sublingual misoprostol. Lowest hyperstimulation, the second best was low-dose oral misoprostol. So comparison with existing literature. So in a study by Chen et al., it was compared Foley catheters, misoprostol and dinoprostone for cervical ripening and labor induction. And it was found that no method actually demonstrated any overall superiority, but vaginal misoprostol was the most effective in achieving vaginal delivery within 24 hours. In a study by Orr et al., where Foley alongside various agents were compared, it included 30 RCTs with 6,465 participants. They found that the time to vaginal delivery were similar with Foley with any of the agents like misoprostol, dinoprostol, or oxytocin. In a study by Alferovic et al., 280 RCTs were included with 48,068 participants. The lowest cesarean section rate was found with low-dose oral misoprostol. This was in contrast to our study where a single balloon catheter with the combination of misoprostol was found to be having the lowest cesarean section rate. Vaginal misoprostol was the most effective in having vaginal delivery less than 24 hours. With respect to this topic, the maximum study, it was the next one where it included 611 RCTs with more than 1 lakh participants. And this study showed that IV oxytocin with amniotomy and vaginal misoprostol was the most effective in having vaginal delivery less than 24 hours. And vaginal misoprostol was the most common agent causing increased hyperstimulation. So the strengths of this study was it avoided any overlapping study. Like said before, if there are two studies that had the same values, then the most recent one was included. And there was no study that was excluded because of language, year of publication, or methodologic quality. The limitations was that there was no comprehensive quality evaluation of each individual study. Clinical and statistical heterogeneity because of confounders were not addressed in the study. Effect modifiers were not similar across study like parity, BMI, cervical status, indications for labor induction, gestational age, differences in labor management, dose, frequency, and routes of administration of various agents, or oxytocin augmentation protocols. Chorioamnitis was not included, and they were unable to make recommendations regarding the frequency and route of misoprostol, and newer methods like Propes were not included in this study. Thank you.
Uma, madam.
Thank you very much, Harini, for
Thank you, ma'am.
putting a fairly complex study into understandable form. Are there any questions from the audience? Deepa, you want to take them together or?
No, madam, we will, I mean, in case of questions to relate to this topic, we can take it as and when, no, madam. There is
Okay.
one question from the audience. Was the misoprostol dose repeated? Like, was it one dose or was it multiple?
So that is what they had mentioned, ma'am. They had not actually told how many doses can be given. The only thing that they had mentioned was a low dose miso means less than 50 and a buccal or sublingual dose means at least 50. They had not told how much is a high dose or how frequently was it repeated, was not mentioned in the article.
So if
I
you want to know, sorry, Dr. Bipin, please go ahead.
Yeah, I want to say something. We have been using misoprostol 25. Now it's very important how you repeat it, whether they
Yes,
have
sir.
repeated it and after how long and how many doses they have used.
Yes,
That is
sir.
one. And high dose means how much high dose? 50? Because
So
that also
the
not mentioned.
So that in the article, it was only specified that the low dose is less than 50. They had not given an upper limit for the high dose, sir. And in their limitations itself, they have mentioned that they have not mentioned how frequently the misoprostol should actually be repeated.
Because see, we have seen many cases transferred to our institution with rupture uterus where misoprostol was used indiscriminately and not knowing exactly how much to use, when to repeat. And one
True,
more
sir.
observation we had when we used misoprostol, there was a higher incidence of meconium stained liquor.
Okay, sir.
Have you, in your practice, experienced this?
We have actually not
Journal
done.
review is different, and what
So
we practice is more important, right?
That is true, sir. But we have actually not done a study like whether there are more incidents of meconium stained in meso or not, sir. We should maybe look into it.
So I think in this study, this is a network meta-analysis, and basically they put together different RCTs and different types of studies together. And if we look into the individual study from which they have collated this data, then the answer to some of the questions that we seek, like was meso repeated, what was the actual dose used in that individual study, we will get to know. Here, they have basically looked to answer the question, which works better in terms of reducing the interval to delivery, increasing the rate of vaginal delivery, etc. And the strength of a network meta-analysis is that you get very large numbers. So even though they say that some of these individual parameters have not been adjusted for, when you have, this many number of women who have been subjected to studies, albeit with different different places, a lot of those characteristics will get adjusted. I think that is the logic with which nowadays more and more we are seeing meta-analysis and network meta-analysis to understand what is the best practice. But clearly for individual practice, as Dr. Bipin said, we need to know what is the dose, what is the protocol, what is safe. But
another point I want to say is, at what point you insert misoprostol? At 3 centimeter dilatation, at what dilatation?
Sure, that's a
or initially when the os is closed.
Is there a Bishop score which was mentioned, like which Bishop score they put and how was?
Yes.
Ma'am, not in this network meta-analysis, ma'am. Like maybe in the individual studies, we might have to go and check it. But as such, in this meta-analysis, they had not mentioned what was the Bishop score, favorability of the cervical status, or when we should, at what dilatation should the meso be inserted. Those were all not mentioned in this particular article.
Yeah, that was the limitation of this meta-analysis.
Yes,
right?
ma'am. Yeah, it was included in the limitations.
And I think a strong message from this one is that a combined induction, where you're putting in a balloon and then using misoprostol, actually gives you a very good outcome.
Yes.
that is the strong message that comes out of here, and it is a relatively cheap method of induction as well. And I think so when we do a balloon and we stretch, intrinsic prostaglandin also gets released, and then the misoprostol acts. So misoprostol doesn't actually work just on the cervix, it starts contractions as well. And that is the reason why one is worried about meconium, as Dr. Bipin said, and other risk of rupture, etc. So, and therefore, ripening with the balloon and then misoprostol is what has been traditionally advocated. But we could do the combination with the balloon in place and use the misoprostol so that you shorten the induction to delivery time. I think that may be one of the messages from this paper.
And there's another question. Yes, sir. Korean, sir. Sorry.
Korean?
Can I just comment?
Of course.
Yes, sir.
I must first appreciate Harini Shree's analysis of the whole meta-analysis.
Thank you, sir.
The issue of the whole meta-analysis you really cannot get clinical outlines from it. Now, whether to use, as a clinician, as Bipin was pointing out, whether to use only misoprostol or use it along with a Foley is something which only the clinician would decide. So what is the Bishop's score? All these factors come out only from the clinical aspect. But if you analyze, as Uma said correctly, we have reached a picture where these two methods, yes, would stimulate well. That's all we can come across. Now, what the side effects, complications, again, not very clear with the whole picture. Thank you.
Thank you, sir.
Thank you,
Thank
sir.
you,
Yes,
sir.
one more question in that. What is the experience with PGE1 suppositories in the present study and the experts, like their views in their clinical practice about propus? How is the effect and other things? Uma?
So I don't think that has been addressed.
Included, ma'am. It was not included.
Yeah, in this network meta-analysis, sustained released PG suppository was not included. Personal experience with the sustained release suppository has been good in our practice. Of course, it is significantly more expensive than the combination of Foley and Meso. But if you take cost out of the equation, or if you have women for whom that cost is not going to be significant, then the advantages are that once it's in for 24 hours. You don't have to repeatedly do a pelvic exam. If the woman ruptures membranes, you don't have to change the method of induction. The prostaglandin is still being released. The only relative negative, which we have found in our practice is that the response is very unpredictable sometimes. So some women actually deliver within 6 to 8 hours of having it inserted. So, you can't quite say, okay, I'll put it in the evening, something will happen in the morning. So that predictability sometimes is not there.
Korean sir, your experience?
We found it extremely expensive. That's the first point. The only advantage I found was if there was a hyperstimulation or any problem like that, taking it off was again very, very simple.
Yeah.
But I've not been very impressed with its action. At the moment, the simplest gadget for me is my misoprostol and also the Foley catheter. We are big advocates of that.
Dr.
Yeah.
Jayashree
Can
Gajra.
I add here about this? Thank you, Dr. Korean and Dr. Bipin Pandit, sir. Dr. Uma, you have taken a lot of efforts, and I must appreciate the meta-analysis presented. And in my experience also, the Foley catheter followed by the misoprostol really works well, especially if it is in a tightly closed os. If you insert the Foley, then it's a good advantage. Only thing about misoprostol, what I find, the potency is again not predictable. Sometimes it works well, sometimes it doesn't work well. So it's related to the, the temperature. I don't know, but many a times I do find that it's quite sometimes it works well, and other times there's no response at all. So we do have one group on optimizing C-sections where we are, having a lot of discussion about this. They are using 4 doses, 6 doses, 8 doses, and there's no response. So any other questions?
Dr. Jayashree, madam, you can unmute and you can talk, madam. Jayashree madam asked, so one tips for that sustained release, it can be, propus can be retrieved early if there is any hyperstimulation. That was the main advantages of using propus. And madam has used many in her practice.
Yeah, but again, the cost is the constraint.
Cost.
Cost is a factor and we have to keep it in mind.
Sometimes hypercontractility is the issue.
No, I think that is something we all see initially, but later we know how to assess the hypercontractility. So it is one of the drawbacks that initially, till you are comfortable, you do tend to take it off more often, or even if you don't, people who are on the labor ward tend to take it off even before. you tell them to. But once we use it more often, it's definitely useful. But certainly, as Dr. Kurian pointed out, cost is an issue.
Okay. So with this, we will move on to the next one. This combined
Anyway,
approach is.
thank you, Harineshri, for an excellent presentation.
Yeah,
Thank you.
thank
Thank
you.
you, sir. Thank you so much, sir.
Okay, so the next is I'll invite Dr. Anandi, Registrar Sitapati Hospital. She's going to present a pragmatic step-based cluster randomized pilot trial, effects of WHO labor care guide in non-cesarean section in India. It is taken from the Natural Medicines, February 2024. And our presenter Anandi is a junior consultant at Sitapati Hospital. Her area of interest is reproductive medicine, high-risk obstetrics, and lifestyle medicine. She is a post-DGO, post-DNB, and post-MRCOG. Over to you, Anandi. You can share the screen.
Sure, ma'am. No, I'm not able to share. I don't know why.
Ma'am, now you can share, ma'am.
You could stop and share.
Oh, okay. Okay, just a second.
Please open the PPT first and then start sharing, ma'am.
Okay, just a second. No, I'm not able to share. I don't know why.
Ma'am, have you seen the share screen icon, ma'am, which is in green color?
Yes.
Yeah. Please click on that, ma'am.
Yes, I'm clicking the desktop, but I'm not sure.
After that, you can see your PPT tab, ma'am, so that if you click on that and click on share, it will be shared.
No, just this.
Or else you can click on the top tab, which is screen tab, which is on top left. You can click on the screen tab and then share.
Oh my God.
Okay.
Or else can you just send the PPT to us in the group so that, like Sahiti, can you just share it for her if that is possible?
Yes, ma'am.
Or email it, Anandi, and I'll share it.
Okay, sure, ma'am. Sure, ma'am.
So in the meantime, we can move on to the next session, madam. Next presenter.
Yes.
Is it okay?
Oh, ma'am, is it okay? Can we go on to the next?
Yeah, of course. Yeah.
Okay,
Yes, yes, of course.
So I'll invite Lavanya. Lavanya, are you ready?
Yes, ma'am, I'm ready.
Okay, so Lavanya's topic is taken it from the American Journal of Obstetrics. The topic is intrapartum ultrasound measurement of angle of progression at the onset of second stage of labor for prediction of spontaneous vaginal delivery in term singleton pregnancy, a systemic review. And Lavanya did her undergraduate and postgraduate from SRMC, currently working as a registrar at Joseph Hospital, Chetpet, and her special interest is high-risk obstetrics, fetal medicine, and published papers in journals and international journals. And over to you, Lavanya. You can start now.
Good evening. So myself, Dr. Lavanya, registered at Joseph Hospital. So before we go to our journal discussion, a common
Lavanya,
note.
you can also, switch on your video if you can.
Yes,
and if your network is good. Yes, thank you. Continue.
Decision making on vaginal delivery versus cesarean in term pregnancy in the second stage of labor is difficult. So let's discuss this topic with our journal for today. Our topic for today is intrapartum ultrasound measurement of angle of progression at the onset of second stage of labor for prediction of spontaneous vaginal delivery in term singleton pregnancies, a systematic review and a meta-analysis. This was published in the American Journal of Obstetrics and Gynecology, published in Feb 2022 by two independent authors, Mr. Ahmed and Kamran. So the aim of this study is to assess the performance of transperineal ultrasound for angles of progression, which is the index test here, at the onset of second stage of labor when complete cervical dilatation was diagnosed. So the type of study here is a prospective cohort studies. And the outcome of this study is prediction of spontaneous vaginal delivery, which is a reference standard year. And the data was collected from PubMed, Web of Science, Google Scholar, Scopus, and Embase from the date of database inception to Feb 27, 2021 by 2 independent authors, as mentioned before. So the inclusion criteria for this study included full text articles in the English language and pregnancy with a singleton healthy fetus at term with a cephalic presentation. Transperineal ultrasound measured the angle of progression at the onset of second stage of labor before pushing. So which means the angle of progression was measured at rest before the patient is down. The exclusion criteria was that only prospective design was included and all other case control studies were excluded. And any non-cephalic presentation, multiple gestation, severe maternal or fetal complication that impacted the labor process was excluded. Insufficient data or test accuracy correct was not included in this study. If the angle of progression was measured during a uterine contraction or during a second stage pushing, it was also excluded. So the methods included in this study was assessed using the Quality Assessment of Diagnostic Accuracy Studies 2 tool. Total 8 studies were included, which was reporting on 887 pregnancies. The overall risk of bias was low in this study. So what is angle of progression? So we measure it via the transperineal ultrasound in the sagittal plane. So you can see on the picture on the left, this is the ultrasound probe, which is held in the mid-sagittal plane. So what is angle of progression again? It is the angle between the line placed through the midline of the pubic symphysis and a line running from the inferior apex of the symphysis pubis tangentially to the fetal skull. So if you look into this middle picture with the diagrammatic representation, you can see a line passing through the midline of the pubic symphysis. So this and another line from the inferior apex of the pubic symphysis tangentially to the fetal skull. So this is the angle of progression that we are measuring. So in the scan picture, on the right side, you can see the scan picture, which shows a line passing through the midline of the pubic symphysis and a line from the inferior aspect of the pubic symphysis to the fetal skull tangentially. So this is the angle of progression. And another picture showing the angle of progression. You can see the angle being more wider and obtuse on the picture on the right than the picture on the left. So the Prisma flow chart, which is a preferred reporting items for systematic review and meta-analysis. So you can see the records which were identified through the database searching was 666 and records identified through the reference search were 4. And the duplicates, after duplicates removal, the total number of studies were 108. And the screened by title excluded were 55. The remaining 53 studies were assessed for eligibility. And the total number of studies at the end included for this meta-analysis was only 8. Only 8 studies were taken into account. So the overall pool results showed a sensitivity of 80, the high significant p-value of 0.0. The specificity on the other hand was 81% with a p-value about 0.06. So this is a forest plot of angle of progression for prediction of spontaneous vaginal birth. So the forest plot on the right shows the specificity and the forest plot on the left shows the sensitivity. So in the sensitivity forest plot, you can see the black dots over here represent the meta-analysis. So totally 8 case studies were included. So if you can see, the overall sensitivity over here was 80% with a highly significant p-value, whereas specificity totally was 81% with a p-value about 0.06. And the angle of progression was subdivided into 3 categories. The first category was 108 degree to 119 degree angle. And the second category was subdivided into 120 degrees to 140 degrees. Category 3 included the angle between 141 to 153 degrees. So based on the angle of progression subdivisions, between 108 to 119 degree angle, the sensitivity was 94% and specificity was 47%. Between 120 degree to 140 degree, the specificity was 81%. Sensitivity was 81%. Specificity was 73%. And 141 to 153, the sensitivity was 66%. Specificity was 82%. So as you can see, as the angles got more wider, the sensitivity kept on decreasing. The specificity on the other hand, as you can see, as the angles got wider, the specificity started to increase. The another endpoints for studies were, for 5 studies had compared vaginal deliveries versus operative delivery. The operative delivery included forceps, vacuum, and cesarean. So the sensitivity for these five studies showed 73% and specificity was 81%. The remaining 3 studies had compared vaginal versus cesarean deliveries. Sensitivity over here was 88% and specificity was 83%. As you can see, the sensitivity and specificity was higher in these 3 studies comparing vaginal versus cesarean. So the strength in these studies included a prospective design, standardized timing of the ultrasound examination, which is the onset of the second stage, and measurements were performed at rest, no pushing efforts between the uterine contraction. In addition, the risk of bias was very low in these studies. So the limitations included in these studies were only a small number of eligible studies were taken into account, and failure to adjust for fetal head position, parity and their effect on accuracy of the angle of progression measurement was not included. Previous studies on angle of progression have mostly evaluated fetuses only in occipito-anterior position. So those in persistent occipito-posterior position have been excluded or have not been assessed separately. So it cannot give you firm conclusion that routine angle of progression assessment at full cervical dilatation can in fact decrease the rate of unnecessary operative deliveries. So the conclusion for this study showed that the angle of progression measured by transperineal ultrasound at the onset of second stage of labor may predict spontaneous vaginal delivery in singleton, term, and cephalic pregnancies. The overall sensitivity and specificity was 80% and 81% respectively. It has the potential to be used along with physical examination and other clinical factors in the management of labor and delivery. Thank you.
Thank you, Lavanya. It was a very nice presentation. So over to Kurian sir. So do you have anything to say? And Madam Sureka Madam has asked 2 questions. How do we translate this information to practice, and what is the cutoff finally you are giving to this study is giving?
At prolonged second stage of labor, the use of ultrasound probe may help in deciding for the operative deliveries. So the cutoff as per this study, they show that the angle between 108 to 119 has a high prediction for a normal vaginal delivery compared to the angle between 141 to 153. So the more the obtuse the angle, the less chances for a normal vaginal delivery, and more in terms of a operative or a cesarean deliveries.
So I think Lavanya has very clearly shown that it's just one of the methods which may sort of come up in future for us to decide, what to do in some of these situations where you are in the second stage of labor. You cannot depend on your digital examination sometimes. And that's when the ultrasound probe, especially transperineally used, is extremely effective. So it's a sort of pilot study, but the meta-analysis shows a large number of cases involved. So we can overall come to some pictures that with this angle measured, we can roughly decide where we can go further. But it's an early study.
Sir, is there a cutoff, sir? As somebody has pointed out, is there a cutoff And what is the time we should be doing this ultrasound?
Ma'am, it should be done once the second stage is diagnosed. When the cervix is fully dilated, we can apply this ultrasound probe and to see the angle. Cutoff as in they have measured, they mentioned only the angle here. Depending upon the angle, we decide for the management.
Anybody has any personal experience?
So generally, when the angle is greater than 140, the chances that you would have a vaginal delivery reduce.
Yes.
So I think that is you know, that is so, and when you look at that sensitivity and specificity, obviously there will be a subgroup where something may work even though this angle is not is between 120 and 140. So I don't think we are at a point where we can use this as an absolute measure, as Kurian mentioned. However, if you're in the labor ward and you're stuck and you have an angle of progression that's greater than 140, you may be less confident in applying that instrument. And, you know, it's more objective in the sense that, especially when there's some caput, this gives you a little bit more objectivity and in terms of application. So if you're really a very experienced obstetrician, this may not influence your decision. But if you're a junior obstetrician who hasn't had too much experience in instrumental delivery, this gives additional confidence that, yes, I will be able to apply an instrument. Obviously, you should have the skills to apply the instrument. But this is one more factor which guides you to say, okay, the angle of progression is, you know, is not very obtuse. Things are looking good. This is not OP. I can apply the instrument and I can do it in the labor room. I think that is the angle from which we use ultrasound in labor.
Madam has pointed out that this study did not include occipital-posterior positions. So where you actually have a lot of dilemmas.
You also have to think of these a situation where the head begins to get extended. That's again a problem going to be it's not going to negotiate the outlet. What about the situation that Uma said about a large caput? Again, we have a situation where with the angle, we are going to get a smaller angle because with the caput, remember that line is going to be at the fetal skull, not at the end of the caput.
Yeah.
So all these are regions where one has to think. Yes, Bipin?
Yeah. Okay.
Bipin sir, yes.
Thank you, Dr. Kurian. What I feel is I'm an old timer, so nothing can replace your clinical judgment, basically. It's an additional tool to help you. Ultimately, your clinical assessment, whether patient can deliver vaginally or you need cesarean, or whether you should avoid instrumental delivery because of this. And again, there are restrictions because they have included only occipito-anterior position. So, as you said, caput is a problem, and turning the head or extension is another problem. So I don't know how far this is going to help you. How accurate this is, sir. Dr. Kurian, your opinion.
Yeah, these are very early days for all these tests. But I think they may come up, we may come up with the scoring using an ultrasound similar to Bishop's. So with time, all these things have to evolve. So that's why I was very happy that this girl picked up this topic. This was the topic which Lavanya picked up herself. And I said, fine, but you must read and analyze and tell us clearly what you mean. So, that's why I said it by way of discussion in a journal, it may lead us to think more about it.
Yeah. I agree, sir, that yes, this is a novel topic. And Lavanya, we must appreciate you for picking this up. And you know,
thank you,
we
ma'am.
also start thinking and start reading what's going on. Is something coming up new?
So there is a question in the chat box. So which has been mentioned that will it increase the operative interference just because the angle is there, are we going to decide on an operative delivery early, or will it
No,
change
no. I don't think that is at all the direction for use of intrapartum ultrasound. It is when you are uncertain, this gives you a little bit more information. And there are other measurements that you can use. There is head perineum distance. You can actually, Dr. Bipin mentioned rotation. So they actually say you can objectively know what is the degree of rotation that is required. Is it under 45? Is it going to be more than 45? And this can be objectively measured, and that is what people who do intrapartum ultrasound showcase as an objective measure, rather than my saying, I think it's 30-degree rotation and you may think it's 50-degree rotation, So that is where we are. Obviously, we have way to go in learning to use it. And unless we use it more often, we won't know whether we are good at it or it actually improves our clinical skills. Because today our operative vaginal delivery skills are dying. So if there is an objective tool that can restore confidence, we should see how we can, inculcate it into our system. So,
Yeah, correct. On a lighter note, today the pervaginal examination is replaced by ultrasonography. That should not happen.
In gynec, it is already replaced, sir. So I think in obstetrics, at least we should
Yes.
not give up on pervaginal exam.
No, but if you want to think sort of on a larger scale, think of the situation where you are doubting it is at that zero station for your operative intervention. You're depending only on the operator's finger.
yeah.
If we had some objective factors like this, I think these were some of the points which I think have to come out from all these experiences. And I think
Correct.
the Indian experience would be very, very valid.
Yeah.
Thanks.
Thank you, madam. Thank you, Bipin sir. Thank you, Kurian, and thank you, Lavanya.
Nice,
It was
Lavanya.
very
Thank
nice,
you.
and it's an eye opener to use use of ultrasonogram in the intrapartum second stage of labor. And thank you, Lavanya,
Thank you,
for
ma'am.
choosing this topic. And we'll move on to the next thing. Anandi, are you ready?
Yes, ma'am.
Yeah, just put it in a slideshow and start.
Good evening to everyone. Today, my topic is about the effect of the WHO Labour Care Guide on cesarean section in India. Does the new Labour Care Guide decreases the cesarean section rate? It is also to understand what is the optimal strategy to implement the Labour Care Guide and its effect on the maternal and perinatal outcome. We know that the cesarean section rates worldwide are rising without a clear medical indication. By 2030, it is estimated that 38 billion women, which accounts for 28.5%, will undergo a cesarean section. Although a cesarean section is an essential component of good quality intrapartum care, it carries inherent risk for women and newborn. Therefore, it should be done only with a clear medical indication. Earlier, we have been using the modified WHO partograph. Definitely, it can determine whether and when an intervention such as a labor augmentation or cesarean section is warranted. However, in most of the situation, it is often used poorly and retrospectively. The reason being inadequate provider training and skills and heavy staff workload. In 2018, the WHO came up with 56 recommendations in improving the intrapartum care and enhance the women childbirth experiences. The key changes were the active phase starts from 5 centimeter rather than 4 centimeter. The action line and the alert line were removed, and there is an evidence-based time limit at each centimeter of cervical dilatation. With this recommendation, the next generation partograph, which is the Labour Care Guide, was developed in 2020. It requires an active strategy to implement that ensures that the healthcare provider clinical practice improve, enhance the quality of intrapartum care, and reduce the use of unnecessary intervention and improve the support to women during labor. This paper was written by Joshua P. Ogle. He's from Melbourne, Victoria, Australia. He's also the first person to assess the usability, acceptability, and feasibility of the Labour Care Guide in 2020. He wrote this paper on the effect of the WHO Labour Care Guide on cesarean section in India. He wanted to evaluate the effect of implementing the labor care guide strategy. The intervention would promote correct labor care guide use by these providers, change their labor monitoring according to the intrapartum recommendation, and management practices. He hypothesized that the use of labor care guide could reduce overuse of cesarean section, and it will improve the maternal and newborn outcome and enhance the women care experiences. It is a pragmatic pilot study, and it is also a stepped wedge cluster randomized trial. To simplify, it involves a sequential transition of clusters, such as hospitals, from control to intervention in a randomized order. As you can see in this diagram, each cluster represents each hospitals, and they undergo a sequential transition from the control group, which is the orange color, to the intervention, which is the blue color, in a stepwise manner. This trial is used in situations where the investigators wants to examine the way in which the impact of intervention develops over a period of time. And it is also used in situation where the intervention needs an initial period of adjustment, that is the transition period, before becoming fully adopted in the setting. If we use a stepped wedge trial, at the end of the trial, all the clusters, that is all the study group, will be exposed to the intervention. It is conducted between 1st July 2021 and 15 July 2022. And this trial was preceded by a 6-month formative phase, basically to change the behavior of the healthcare provider. They used a COM-B model, which recognizes that the individuals must have the capability, physical and social opportunity, motivation to perform a behavior. They also used co-design principles and primary data collection. They included provider training and audit and feedback activities. The intervention was then introduced in a stepwise manner in 4 public hospitals in the state of Karnataka in accordance with the randomization schedule. The sample were 4 public maternity hospitals in the state of Karnataka. They included hospitals who has the capacity to provide comprehensive emergency obstetric care and who has more than 4,000 women giving birth each year, and their overall cesarean section rate of 30% or more. Each hospital was treated as a cluster. They appointed 2 senior obstetricians as facility investigators, and they were responsible for the trial activities at their hospital. The target of the intervention were labor ward staff, including the obstetrician, postgraduate doctors, and nurses. As you can see, this trial diagram shows the number of gestational women whose gestational age is more than or equal to 20 weeks. The 4 clusters represented each hospital, and each sequence has a different schedule of control condition. As you can see that the gray box is the controls, and they undergo a sequential transition from control to the intervention. The intervention is marked by the dark blue. They also have a 2-week transition period, which is marked by the light blue. So each of the hospital will undergo a stepwise transition. The 4 clusters were randomly assigned by the computer-generated list. The allocation sequence was initially concealed in the control group, whereas once the intervention was applied, the blinding was not possible. The intervention was commenced in hospitals according to the randomly assigned sequence. The control group were the women in whom the labor was monitored using the WHO modified partograph. Initially, during the formative phase, they found that the partograph was used inconsistently and oftentimes retrospective. Therefore, they conducted training seminars to standardize the control condition. They also applied the WHO intrapartum care recommendation at the start of the trial itself. The intervention was applying the labor care guide. They included a co-designed labor care guide training program for doctors, which included a 2-day workshop. And they also repeatedly conducted the 8-week low-dose high-frequency training every 3 months. They also conducted monthly audit and feedback process using hospital cesarean section data. Initially, the sample size was difficult to estimate because there was no previous trial. In 2020, these 4 hospitals collectively averaged about 24,000 births, and they had a cesarean section rate of 44%. And in Robson Group 1, all hospitals, the cesarean section rate was at least 40%. The trial was designed to provide a 92% power and to detect a 25% reduction in the Robson Group 1, which is a low-risk primee who comes in spontaneous labor. The sample size was at least an average of 300 women per cluster per time period. But in this study, they had 11,624 women in the control group and 14,971 women in the intervention group. The analysis was done by intention to treat principle, and they used a generalized estimating equation method to estimate the effect of intervention. A bias correction method and degree of freedom approximation was done. The relative risk and 95% confidence interval was reported as the size effect, and it is done by using the REDCAV, which is a web-based software platform. The primary outcome was the use of cesarean section rate in the Robson Group 1. The WHO advises that the cesarean section rate should at least be less than 10% in Robson Group 1. Secondary outcomes were intrapartum intervention like cesarean section, augmentation, ARM, episiotomy, and operative vaginal delivery. And they also analyzed the effect of maternal and fetal neonatal mortality and morbidity. Also, women experiences of care using a pre-tested interviewer administered survey was completed by postnatal day 7 or discharge, whichever came first. As you can see in this diagram, this is about the baseline characteristic. You can see that the maternal age, previous cesarean section, gravida, parity, and the women receiving antenatal care, gestational age at the time of birth were similar between the both groups. That's the control and the intervention group. This is regarding the primary outcome. As you can see, the cesarean section in the Robson Group 1, 39.7% underwent cesarean section in intervention and 45.2% of women underwent cesarean control. There was a 5.5% reduction, but again, it is not statistically significant. The augmentation with oxytocin during labor was reduced by 18% in the intervention period. The rest of the analysis, the cesarean section in group 1 and 3, combined group 1, 2, 3, 4, 5, there was not much difference. And there was not much difference between the episiotomy, operative vaginal delivery, and artificial rupture of membranes. Coming to the secondary outcome, 3rd or 4th degree perineal tear, PPH, stillbirth, neonatal morbidity, and mortality, there was not much difference between the two groups. Coming to an interesting analysis about the women experience outcome, most of the women, that is about 98 to 99% of the women, they felt that they were very satisfied with the amount of the time the healthcare provider spent with them. And they also were very satisfied with the way the health provider communicated with them. But again, less women reported that they have been offered pain relief or they have been asked about the birth position they prefer. Definitely, there's a substantial gap in providing the supportive care, and that needs to be addressed. Although the cesarean section rate was reduced to 5.5%, is not statistically significant. However, the findings do not preclude the possibility that the labor care guide may reduce cesarean section and augmentation in larger definitive trials. In 2022, Pandey et al. Conducted a very small study, including a 271 low-risk women in a single hospital, and they compared the effects of labor care guide with the modified partogram, and they reported a dramatic reduction of 1.5% cesarean section rate in the intervention group compared to 17.8% in the control group. And they also reported a significantly lower oxytocin use and shorter duration of the active phase. However, in the study group, they followed the Lakshya principle, which is in line with the WHO recommendation. So it is easy for them to create a behavioral change. But however, when we generalize to other settings where they are very new to the respectful maternity care, it will need a good strategy to implement the labor care guide. It is also more challenging to generate the provider behavior change in settings. Contextual differences around how frequently obstetric interventions are used, as well as the differences in the risk of profile of obstetric population, mean that the labor care guide has variable effects. The strength of this study, they used a theory-based evidence-informed co-design approach to implement the labor care guide, and they addressed the factors which is known to impair the partograph use. They used a robust cluster randomized design and recruited a large number of participants, about 14,000 women in the intervention group. They used a step wedge design, means that all hospitals were implementing the labor care guide strategy at the trial conclusion. The sample size was met. The limitations were, as this was a pilot trial, they cannot draw definitive conclusions on the magnitude of labor care guide on primary and secondary outcomes. Therefore, further definitive trials are warranted. They are not able to test a superiority hypothesis for rarer adverse outcomes. Even though there was no short-term harms, definitely it cannot be generalized to all populations. Confidence interval were quite wide. This is because of the variability in the outcome rates. Therefore, larger trials with more clusters is needed and in different population settings. So how this can affect our clinical practice? Definitely, it improves the quality of labor and childbirth care and reduce the overuse of intrapartum intervention. Women also had higher level of satisfaction with the amount of time the healthcare provider spent with them and the way they were communicated with and the overall birth experiences. But further evaluation and larger scale are warranted. Till now, there is no evidence to say that the labor care guide decreases the cesarean section rate. Substantive gaps persist in the provision of supportive care around the time of birth. Therefore, additional strategies are needed to address these gaps. So together, we can change and we'll move forward to tackle our greatest challenge like reducing the cesarean section rate. Thank you.
Thank you, Anandi. Very nice presentations, and you clearly explained the step-wise, what is step-wise, what is a cluster randomized pilot trial. And one questions from me before asking the experts, why they choose this design? Because this design anyway, it's not limited with the primary and secondary outcome. Why other designs? I know it is out of the topic. I'm just asking why they choose this design in evaluating the effectiveness.
The step-to-which randomized trial, ma'am.
Because
when
your
the-
outcomes, primary and secondary outcomes has not been success in this design, right?
Yes, ma'am. But again, when we use a new intervention and we apply to the population, if we use a randomized control trial, there'll be a control group and there'll be an intervention group, ma'am. But we implement a new intervention, it needs a transition period. And definitely all the clusters should be exposed to the intervention before we study them. So that's why they use the step-wedge randomized trial, ma'am.
Thank you. Over to Uma, ma'am. Bipin, sir?
Thank you, Anandi.
Yeah, Anandi, nice presentation.
Thank you, sir.
The whole idea is to reduce the cesarean section rate, which is skyrocketing, especially in India and some of the states with a lot of criticism, and government is thinking of coming out with a hardline rules. Now, you mentioned something they had used partogram.
Yes.
Did they use it for all patients, or they recommend to use for all patients?
Yes, sir.
Because I feel partogram is extremely important and very important. In fact, my thesis as a student was on partogram, and it helps to some extent to decide which way the labor is progressing. I want to know your experience, madam, and Uma madam, and Kurian sir, about partogram. This little divergent, but
Yeah, I think we do use the partogram. Now, more recently, we have moved to using the labor care guide in our practice. So it's, to the extent that we are now, we can wait longer. I think where it makes the biggest difference, the labor care guide, is that in the first stage of labor and in latent phase, as long as everything is okay, we can wait longer. We are not saying at 4 centimeters she hasn't progressed in 4 hours and therefore we are going to section. I think that is the biggest change that has happened. And certainly partogram, in terms of monitoring a patient in labor, it does give value. LCG additionally ensures supportive care, etc. What was interesting in this study is it actually didn't translate. So they wanted a bigger reduction in section rates. There was a reduction, but the reduction was not what they, was not statistically significant because it didn't reach the reduction that they thought it would reach.
Dr. Devyani, you want to ask some question?
yeah, here I want to mention one name. Partogram was made quite popular by Dr. Daftari, SN Daftari from Bombay, and he made little modifications about alert line and action line, and it was quite useful. Unfortunately, it is not used that frequently, even in Mumbai. Everybody's in a hurry to do cesarean, that's why.
Bipin sir, at our place in Varda, we have been using the electronic martograph. I hope I'm audible.
Yes, madam.
Yes, yes.
Because we noted that the partograph, instead of feeling prospective, the students used to, first deliver the patient and then fill it prospective, just for and just attach it. So for that, we started with the help of Jeevdaya Foundation. The electronic partograph was started, which you had to fill it at the particular time. Otherwise, if it was retrospective, it won't take that particular entry. So it was done for all patients. So we trained the ANMs to fill the electronic
Good.
partograph. So it was done for all patients. What I'm noting with LCG, Uma ma'am, is taking a lot of time for people to transition from partograph to LCG. And people are not favoring LCG very much, though, as you rightly pointed out, it has advantages. It has those, it gives us those decision making that yes, we can wait more. We can, the supportive care and all those have been inbuilt in the LCG. But why do you think that the transition from partograph to LCG? In fact, in many of the medical colleges and large hospitals, the labor care guide is not being used. And partograph also, as Dr. Bipin Pandit pointed out, not being used by many.
Actually, even in this stepwise, in this study, if you notice, and Anandi presented, she also highlighted that even though the partogram was in use, most of the time it was retrospective or incomplete. So, and they took, was it 2 months for the transition? There was a two week, there was a pre-study orientation, and then there was a 2-week transition. I think you have to take, if you want to transition, you should take off the partograms and only have the LCG there. But it is more tedious to fill.
Yeah,
I think the other challenge with the LCG,
you have to really, it is quite tedious. It takes more detailed, attention. It can't just be filled like that.
Dot and cross and go away. But the bigger challenge is what happens to all those women where something needs to be done before they get to 5 centimeters.
Yeah.
They are, it's okay if they're comfortable and we are not offering pain relief, it's fine. If you have a distress before 5.
We did have those ANMs trained. So till the time the ANMs, it was in the project format. So for 2 years, we did have those ANMs, and then of course, it was required that the residents should be doing it. So, so when the ANMs are there, additional help is there to fill in the details, they'll use it, the tool. And when there's no such help, usually the residents won't use. So in fact, even though it is proven that this tool is so very important for decision making, still the usage, is not so good.
So true.
Really,
And the partogram is extremely easy to use, but unfortunately, I call it postnatal partogram. It is filled up afterwards.
So I was also curious as to why, though the LCG allows us to wait longer, there wasn't that much of a reduction in section rate. I don't know, Kurian, any thoughts?
Yeah, I was, after reading the article, it looked, the simple principle is you watch better, your results are going to be better.
Yeah. Yes.
There's nothing else in the whole thing.
True,
so if you
but
watch
it didn't.
A patient more carefully, you'll find you're ending up with better results. So the problem where we have to draw a line is where we are not able to watch like that. So that is where either your partogram or your LCG, whatever you use, you're going to have trouble. Now, the big advantage of the partogram was that it could be handled well by the nurses and the midwives.
Yes.
So that is a point which I think we have to emphasize. I don't know when the LCG is going to be handled so well by we may need our residents to do that work. So let's see about that. But I think even with this, it's early days. Maybe your study in the hospital will tell us, Uma, whether this would be better or not. I've still not become a big advocate of LCG.
We started using it when we implemented the WHO obstetric checklist. That is when we had to do this. That obstetric checklist actually increases the workload on the obstetric unit.
This is the biggest problem with many of these managements.
Yeah, it's
If
very,
you're going to increase paperwork,
yeah, you need a secretary.
You don't look at the patient. That's what's worrying me.
Yeah, very true. Very
So
true.
let's draw a line. What do you say, Bipin? Old world?
Yes.
True.
We are old timers. No, but another question, since it is just not related, but how popular is continuous epidural in South India?
In pockets only.
It helps for
we use it
like analgesia, and the cocktail
not
anesthesia.
in the public sector. Yeah, public sector, it's still not available. So even in the private sector, only some of us.
It helps in dilatation, sir. Dr. Kurian will agree. If you give at the right time, we used to, when we were students, we used to give pethidine and all. Now it's not available. But otherwise, Fortuin compose combination, which Dr. Daftari advocated, at the right time, it helps in dilatation and progress of labor. What is your experience, sir?
It'll keep the patient quiet, and suddenly, before you know, it'll be fully dilated. But then I don't think those stand scrutiny right now. Yes, Uma, shall we go on to the next case?
We can. So the reason, one of the reasons this article got picked is it's a study from Karnataka. So we can do this kind of work in our country, though it's led by somebody in Australia. Maybe it's time has come for us to plan and do these things ourselves. Okay, over to the last presentation. Thank you, Anandi.
Thank you, ma'am.
Sorry, ma'am. Sureka, ma'am, can you just put the message in the chat group? They want to know the electronic partogram, the details. So can you just message madam in the chat group?
Yeah. I'll invite Bharati. Can you share your screen, ma'am? Bharati talk is on tranexamic acid as an adjunct to oxytocin prophylaxis in the prevention of PPH in women undergoing elective cesarean section. That is again a single center double-blind randomized control trial. And she did, Bharati did undergraduate and postgraduate from SRMC. Currently as a registrar, she has a special interest in high-risk obstetrics and gynae endoscopy. She also presented multiple papers. Over to Bharati.
Yes, ma'am. Thank you for the introduction, ma'am. Good evening to everyone. Today my topic is on tranexamic acid as an adjunct to oxytocin in the prevention of postpartum hemorrhage in women undergoing elective cesarean section, a single-center, double-blinded, randomized control trial, which was published in BJOG, an international journal for obstetrics and gynecology, in the month of March 2023. The authors were Hui Li, Michel, and Shepali Thakur. Introduction. Postpartum hemorrhage, which is the leading cause of maternal mortality and morbidity, it contributes about 25% of all pregnancy-related deaths. Tranexamic acid, which is an antifibrinolytic agent, which competitively inhibits the activation of plasmogel to plasma. It has proven to reduce the blood loss and transfusion requirements for various non-obstetric and obstetric elective surgeries. Tranexamic acid arrests bleeding by inhibiting the fibrinolytic system that is activated during placental separation if used early. WHO recommends prophylactic urotonics to prevent postpartum hemorrhage. Women trial, which is World Maternal Antifibrinolytic Trial, has concluded that tranexamic acid reduces the mortality due to bleeding in women with PPH. RCOG also has recommended considering the use of prophylactic tranexamic acid only in women at high risk for PPH undergoing cesarean section. The aim of the study is to evaluate the effectiveness of prophylactic tranexamic acid in reducing the calculated estimated blood loss in women with or without risk factors for PPH who are undergoing elective cesarean section. The type of the study is a single-center, double-blinded, randomized placebo-controlled trial conducted between June 2020 to October 2021. The data source from the study was done in the Department of Obstetrics and Gynecology, KK Women and Children's Hospital, Singapore. The inclusion criteria were women aged more than 21 years or older undergoing an elective cesarean section were eligible to participate. Exclusion criteria, patients who were anternatally diagnosed with placenta accreta spectrum, hypersensitivity to oxytocin or tranexamic acid, thrombophilia or coagulopathy, or with history of thromboembolic events, severe cardiac or renal or liver disease, poorly controlled hypertension, severe preeclampsia or eclampsia. Methods. The patients who are high risk for PPH were considered to be with BMI more than 30 kg per meter square, parity more than or equal to 5, prior history of postpartum hemorrhage, pregnancy associated with fibroids and adenomyosis, and maternal anemia. Participants, regardless of this risk status for postpartum hemorrhage, were randomized to receive intravenous tranexamic acid 1 gram or placebo, which is 10 ml of normal saline with a 1:1 allocation ratio. One of the blinded study team members administered tranexamic acid and or placebo intravenously 10 minutes prior to the skin incision. But all the patients who was randomized also received the 5 units of oxytocin, IV oxytocin, according to the active management third stage of labor. So, assist for eligibility, a number of patients were 991. Excluded from the study was 791. Did not meet inclusion criteria was 241. Declined to participate were 5. So, there were totally 200 patients were randomized to 2 groups, placebo group and tranexamic acid group. One patient from the placebo group withdrew, and 2 patients from the tranexamic acid withdrew. In placebo group, primary outcome was not measured in 7 patients, and people who received additional tranexamic acid were 8, which were added to the tranexamic acid group. Here, in both the groups, the assessment for the primary outcome was done in 2 population. That is, intention to treat population and per protocol population. The per protocol population study assessment is it is analyzed whether the effect of the drug on the patient who are fully compliant. The intention to treat protocol analyzed that every patient randomized to clinical study should enter the primary analysis. So patients who have dropped out prematurely, compliant to the study, or even patients taken the wrong study treatment were also included. So the primary outcome is by calculating the estimated blood loss, which is estimated blood volume into preoperative hematocrit minus postoperative hematocrit by preoperative hematocrit. The estimated blood volume is calculated by the body weight in kg into 85. That 85 is average blood volume in ml per kg. The secondary outcome is gravimetrical estimation of the blood loss during the surgery. That is, weighing the number of swabs, drapes, volume of suction and aspiration, and estimated blood volume, which is assessed by the surgical team, and drop in hemoglobin post-operatively. Also, for need for additional surgical interventions and other additional medical interventions and maternal and neonatal adverse events. Intention to treat and per protocol analysis for primary and secondary outcomes were performed. Subgroup analysis comparing the outcomes of women who were high risk and or low risk for PPH was also conducted. The results. Mean estimated blood loss was significantly lower for women who received tranexamic acid, which was around 620 ml. Those who received placebo, the mean estimated blood loss was 750 ml. The mean difference was around 126 ml, which contributes to p-value of 0.035, which is statistically significant, and null hypothesis was rejected. The proportion of women with the calculated estimated blood volume, blood loss of more than 500 ml, and calculated estimated blood loss of more than 1000 ml was lower in those receiving tranexamic acid than in those receiving placebo. But the adjusted risk did not reach the statistical significance, which was p-value was 0.1. The need for additional urotonics or tranexamic acid and the need for surgical intervention and the need for blood transfusion did not differ between 2 groups, where the p-value was more than 0.05. While those people who in tranexamic acid group had a lower percentage of drop in hemoglobin, where the p-value was 0.01, which is statistically significant. Women at high risk for PPH had significantly lower calculated estimated blood loss with tranexamic acid. Notably, tranexamic acid reduces the proportion of women with calculated estimated blood loss more than 500 ml and as well as with more than 1000 ml. The subgroup analysis for women at high risk for postpartum hemorrhage was only carried out for 2 groups. That is, for one group who had BMI more than 30 kg per meter square and preoperative hemoglobin less than 10.5 grams per deciliter. Tranexamic acid was found to reduce estimated blood loss in women with preoperative hemoglobin less than 0.5 with contribution p-value of 0.09, but not for women with more than BMI 30 kg per meter square. The limitation for the study was underpowered for certain subgroups in secondary outcome, such as those with specific risk factors for PPH. Subgroup analysis could only be done for women with BMI more than 30 kg per meter square and those with preoperative hemoglobin less than 10.5 grams per deciliter. The strengths of the study: use of calculated estimated blood loss as the primary outcome, which provides an objective estimate of blood loss. The recruitment of participants with multi-ethnic backgrounds provides a good representation of the diverse Asian population. The inclusion of women at high risk for postpartum hemorrhage in this study, a group not commonly included in other trials. So conclusion, 9 women defaulted on the postnatal follow-up, 4 from tranexamic acid group, 5 from the placebo group, leaving 188 women with complete follow-up data. There were no maternal thrombotic events. 2 women reported unilateral leg swelling, but had negative ultrasound Doppler. Those 2 women has received placebo during the surgery. Neonatal outcomes were similar for both groups. Hence, prophylactic tranexamic acid should be considered in women with risk factors for postpartum hemorrhage, and those most likely to benefit are those with preoperative hemoglobin less than 10.5 grams per deciliter. Further studies are required to validate the role of tranexamic acid in women at high risk for postpartum hemorrhage. Ideal dosing and timing of tranexamic acid administration, its cost effectiveness and adverse effect profile remain important association to be explored. Thank you.
Thank you, Bharati. That was a nice insight on tranexamic acid if as a prophylaxis as in active management of third stage, but you are not giving it as an active management of third stage, right?
No.
Yes, ma'am. As for all these patients, they have also received that AMTS, ma'am, which 5 units of IV oxytocin also has been given for both the groups, ma'am, here in this study.
Yeah. Over to you, Priyansa.
I think it's a very interesting finding. If you categorize it into groups like high risk, what is the harm done if you're going to give tranexamic acid? If you're going to decrease the blood loss, I think one would consider it very worthwhile. So that was the only point in the whole paper which I found very. The other one was the calculation of that estimated blood loss. That's where we all get very, one will say it was 400, other will say 500. The calculation is very simple. And this is again from an Asian country. This whole thing, paper is from Singapore. So there they've had people which patients very similar to us. So these were the points in this paper which were interesting, and I think we could try it out in specific cases. Although all their patients had oxytocin in addition to tranexamic acid. Any questions from anybody on that?
Dr. Korean, Dr. Surekha here.
Yeah.
2 of my students are doing thesis on this subject. One is doing on vaginal deliveries, one is doing on cesarean section. The estimation of blood loss in cesarean section is a real major challenge. Because for vaginal deliveries, we have those brass V drapes, and it's not at all an issue. But for cesarean section, as pointed out in this paper, they measured the drapes, they measured the mops and all, But let me tell you, practically, it's very difficult. It's very challenging. Even in a research setting, to take off all the drapes, measure them. It is really difficult. Any other innovative idea of measuring the estimation of blood loss? I read about the AI tools which can take pictures of the drapes, and the AI will tell you what is the amount of blood loss. What do you think? Really, measuring the drapes and all, is it practical? Is it feasible?
It's very difficult, but I don't think we have much choice at the moment.
Sir, is there anything, I don't know. I've been reading a lot about this estimation of blood loss. We couldn't find anything, especially for cesarean sections. We tried to have our own local we try to create one sort of a tool made up of the plastic wraps we have, but it's very difficult to exactly measure the blood loss, even in research settings.
I agree with you.
Uma ma'am, anything to say on this?
It is difficult. In fact, there is the C-Safe project that's happening in Telangana, and they're the same group that did this emotive trial, and they're measuring. So they have a drape, but again, they want 2 suction machines, one for the Leica, one for the blood. It's not practical. I mean,
Not practical. And
it's
that's
not-
why what is happening, the early diagnosis, the emotive trial, the E says early diagnosis,
Yeah.
isn't it? And now they are saying 500 ml blood loss also in C-section also should be considered as, excessive blood loss. So when do we say that 500 has reached? If we just say visually, then it's not an objective assessment at all. And
Yeah.
early diagnosis, the first thing we are not doing well, so we are not treating. So maybe what this trial is saying, using tranexamic acid as a prophylaxis, if we take, yes, they have really done the objective measurement. I'm skeptical still. How did they measure? Drop in hemoglobin is fine. Drop in
Yeah, but
hemoglobin post-operative is fine. We can, accept that as an objective tool. But actually measuring the blood loss, it's very, very,
difficult.
very challenging. In fact, my student is still very much perplexed what to do.
On table to measure is very difficult. Accuracy, it's not possible. Only thing is to count mobs.
I
That's
can
all.
help us.
And see look at the suction bottle, but the liquor is also mixed with it, so it's very difficult to.
Yeah.
But as far as tranexamic acid is concerned, I think it's a fantastic drug, and there are no side effects. There's no disadvantage in giving. There's only advantage, so it's worth trying. Some obstetricians give it routinely for all seasons. I'm
We have
not
started
sure
to
whether
give that
it's.
now. Because definitely in vaginal deliveries, it's the results are definitely very good. Along with oxytocin, we give tranexamic acid as well.
Yeah.
Unless people are using carbitocin. So carbitocin as it's, now a lot of takers for carbitocin.
Tranexamic acid is used for all trauma now. Tranexamic acid is used even in our gynec surgery, endoscopy.
Yeah.
So in all these factors, we know it benefits. So once we can try using it, there's no harm. And as Bipin said, it's got no side effects, at least that we know of at the moment.
So what time difference between the surgery and tranexamic acid you all recommend? So that's in the chat box as well. Question they are asking. 1 hour before surgery, time of, like, what is the time difference between the surgery and the tranexamic acid?
Yeah, you usually anesthetists give it. See, it's not. After induction also you can give it. I don't think it acts very well. IV.
No need
No
for
need
that
to 1 hour before.
I think in this study, Bharati said it was given at the time of induction.
Yeah, at the time of induction.
Fine.
Normally, anesthetists don't like to give anything else at the time of induction, besides their drugs. But after the patient is stable, they can give.
Yeah.
You're slowly making them change.
Yeah, usually is used, but they like to watch for a while, for hypotension or any reactions, and then probably
allergic. Sureka ma'am, there's a question about what is the company which gives that electronic part of
with Jeevdaya. It has not come out as in the market. We did it with the Jeevdaya Foundation. They had their own system. They developed it. We gave them some feedback, and then the whole system was developed, and we use it in the project format. It hasn't come out in the market as a, as a product.
Okay.
And then of course the LCG has come, and so, so it has not come up in the market, but it is definitely a very nice tool. Especially where, in large setups and multiple interfaces can be used. We can even, if I am sitting at home also, I can see on my screen how many people are in labor, what is their photograph, like that.
Okay.
I can monitor from home as well.
So there is an app along with it on your phone?
Yeah. You can do it from the phone, you can do it from the computer. In the laptop, you can see how many women are in labor, what is the photograph of each one of them, has the resident filled in the per vaginal examination or not. You can take decisions. So it's a very good system. However, it hasn't come in the market yet.
Good.
Good.
We just hope that it comes to the market soon.
Then we can also incorporate continuous ETG monitoring into it. And then as the presenter says about the second stage ultrasonogram also we can put it, and we can go at the right time and deliver the baby.
Yeah.
Excellent.
Really lot of challenges in vaginal deliveries, especially, with the type of aggressive patients we are getting nowadays. But still, we do find that with, this alternative birthing position, analgesia, so many things we are trying to do, birth attendance, we do find that there is a difference.
Birth attendance is like, it is really giving a drastic difference. It
Yeah.
calms the patient.
Thank you, ma'am.
Thank you very much.
Thank you, sir. I
Thank
would
you, sir.
like to specially
Thank you.
thank the moderators, Dr. Uma, Dr. Korean. It is really very, very, for us, it is a learning process that both of you have taken such a lot of efforts. And Dr. Bipin Pandit joining as the expert. Thank you so much from the Clinical Research Committee. And Priya and Deepa, both of you are doing wonderful job of choosing the institutions, the moderators, the papers. It's a really great learning experience for me personally. Thank you so much.
Thank you,
Thank
ma'am.
you.
Thank you. Thank you, Deepa. Thank you, Priya.
Thank you all the
Thank
participants.
you. Thank you. Thank you,
for
sir.
joining today.
Thank you very much. Bye.
Presenters
Thank you.
as well, you have done a really great job.
Sure, ma'am.
Thanks for the opportunity. Thank you very much.
Thank you, ma'am.
Thank
Bye.
you. Thank you for
Thank you,
joining.
Sarita, madam. We'll see you in 18th in Chennai.
Yeah, I'm coming.
You
I'm
are
coming.
coming. Yeah.
Yes, ma'am. That's a in-person meeting, clinical research.
Yes, I'm
Happy-
coming.
We are
Thank
eager.
you.
Thank you so much. Thanks, Priya. And thanks, Sagiti and Chitrakala from Shield Platform for giving us the platform for the Oxy Journal Cups. Thank you so much. Vijay, madam, is there?
Webinar. No, Vijay ma'am is not there.
Okay. Priya, bye-bye.
Okay, thank you. So on behalf of Oxy, we would like to thank everyone who stayed till the end. Thank you very much, and we are looking forward to it. I mean, we'll try to invite you. Please come and join us in person on the 18th of this month for the in-person webinar on the Clinical Research Committee. Thank you all.
Congratulations, Ra.
Thank you,
Thank
Kundavi,
you,
madam.
madam. Thank you for staying till the end, madam. Thank you. உங்களோட question பார்த்துட்டே இருந்தோம். Thank you.
Thanks, Kundavi, madam. Thanks, Dana, madam.
Very nice paper, Deepa and Priya. Great job.
Thank you, madam. Thank you.
Day by day, you people are rocking.
From 18th, join us for in-person
Join us.
CME.
Younger?
Saturday in Alvapet Raintree Hotel.
Okay.
Afternoon. I'll send you the invitation, madam.
Sure.
Okay.
Thank you, ma'am.
Thanks,
Thank
Dana,
you.
madam. Okay, Priya, shall we leave?
Yes, ma'am. Yes. Thank you.
Bye.